Okay, well, good morning, good afternoon, good evening, everyone. And for those of you in the live audience, thank you very much for joining us. And today we have three very eminent panelists to discuss with us about inequity in pandemic outcomes and in pandemic response. My name is Arinaminpathy. I am a professor of mathematical epidemiology at Imperial College London and in the Jameel Institute. And I have to say I'm not an economist or a policy analyst myself, and so I'm looking forward very much to learning from our discussion today. Now, before going on to introduce the panelists, I just wanted to make a couple of comments just to try and hopefully frame the discussion. So we often talk about inequality and inequity as two almost interchangeable terms, but these are terms with subtle differences. And it's maybe helpful to bring that out first before starting the discussion. And the panelists can correct me in this, and please do. But inequity, when we refer to that, we're often talking about differences in outcomes, for example, that arise as a result of avoidable shortfalls in policy and governance. And on the other hand, when we talk about inequality, these are differences in outcomes and so on that arise from things that perhaps they perhaps don't arise from policy failures in the same way. So, an example of an inequity, for instance, is that we know that people from lower socioeconomic groups, for instance, were less likely to be able to observe social distancing, and therefore were more likely to be exposed to COVID infection because of living in more crowded living conditions, for example. And even when they got COVID infection, they were more susceptible to severe outcomes if they developed symptoms, as a result, for example, of poorer access to healthcare, to good quality healthcare. And these were things that could be addressed through improved policy and improved governance. And on the other hand, inequalities, an example of an inequality might be, for example, we know that older age groups were more susceptible to severe outcomes of COVID infection. And so this is something to do with age. This is not necessarily something to do with a policy failure. It is rather something arising from the biology of the virus itself. But of course, it could also attract policy interventions, for example, interventions that were specifically focused at protecting older age groups from the most severe outcomes of the disease. And so in the discussion today, what I'd like to do is to focus on a bit more on inequities. These are basically policy shortfalls that have, if you like, a justice or fairness element to them, because we'd like to understand what it is we've learned from the COVID-19 pandemic and what we can do better in order to protect the most vulnerable in future pandemics. So just a practical point before we go into the panel discussion. For those of you in the live audience, we do also welcome your inputs and your questions as well. And so if there were questions that you would like to put to the panel, then please do use the Q&A facility. Please also note that the session is being recorded, so if you wanted to be anonymous, then you can select that option in the Q&A facility. But we do welcome your comments and questions. So what I'd like to do now is I'd like to invite each of the panelists to give brief comments, perhaps about 5 minutes each, before we then go on into the broader panel discussion. So I'd like to start with Professor Indrani Gupta, and just to say a couple of words by way of introduction to Professor Indrani. She's professor and head of the Health Policy Research Unit of the Institute of Economic Growth, IEG, in New Delhi, India. And Indrani received her PhD in economics from the University of Maryland in the US. And she set up a Center for Health Economics and Policy Research in her institute, and this was the first of its kind in India. And Professor Gupta's work experience has been diverse, and it includes teaching as well as work in academic institutions, the World Bank, and the Government of India. And her areas of interest cover a wide range of topics in the area of health economics and policy, and include demand for health and healthcare, health financing and coverage, poverty and health, and cost effectiveness, and the economics of diseases. Professor Indrani, over to you.
Thank you, Nim, for this nice introduction, and a big thank you to Jameel Institute for inviting me for this very interesting symposium. I'll be very brief in my comments. I'll talk a little bit more about India. I'm most familiar with that country. So I just want to start by saying that when the pandemic struck us, most countries were ill prepared to deal with a catastrophe of this nature. But countries such as India, we already had significant inequities and inequalities. The inequities, economic, social, and political, between groups, areas, regions, there were overlaps among the vulnerable population defined across a broad range of parameters. And almost all the vulnerable population that we now name have overlapping multiple parameters of deprivation, social and economic and political. So, for example, in India, there are major overlaps in groups defined based on different parameters. Of course, the poor, the scheduled caste and tribes, social class, women, religious minorities, sexual minorities, those with little or no education, people living in inaccessible terrains and strife-torn areas, and also in backward states and districts that the government officially has talked about. Now, I liked, Nim, your remarks about the difference between inequality and inequity. And, you know, the existing inequities are essentially, much of it, and for most of this, are policy driven. And we have been ignoring these vulnerable groups for years. And therefore, when the pandemic actually happened, the inequities were huge among these various groups. I want to talk about the two features that I'm most familiar with in the pandemic. I mean, there is a lot to talk about, but let me restrict my comments to healthcare and livelihoods. Now, the two notable features of these groups, these overlapping groups, would be their access to healthcare, including almost complete lack of health coverage, and total lack of social protection. India doesn't really have any good social protection programs, including health coverage. Now, while the COVID pandemic itself did not distinguish apparently between groups, the measures adopted to deal with the pandemic ended up by doing so. So there is some broad consensus, of course, that the lockdowns and restrictions did stem mortality rates, and also the governments did not have much of a choice, and most of the governments reacted in a knee-jerk fashion. Of course, the Indian government did it in a completely knee-jerk fashion, and there have been competing harms and benefits, and the costs have fallen disproportionately on the vulnerable. Thus, for example, the mobility restrictions, the economic restrictions, social distancing, complete lockdown ended up harming those with little or no social capital actually to deal with the consequences of these measures. Now, the areas that I want to touch upon, health and livelihood. Let me start with health. We already have serious issues around accessibility, affordability, and availability of quality healthcare. And this falls much harder on the vulnerable populations because we have no coverage, and the public healthcare system is actually really literally falling apart in most states, especially the backward states. And the out-of-pocket expenditures are very high, so we depend on the private sector. And that has ended up impoverishing households and deepening poverty. So while there is no data actually to rigorously validate this, the complete shutdown of non-COVID health services during the pandemic would have impacted, of course, all, but must have worsened the health-seeking behavior of the vulnerable population, and therefore the health outcomes of these groups. And this includes shutting down reproductive and child care services as well. I'm on the Lancet Commission on Gender and Health, and we have been recently looking at the extent to which countries have been implementing gender-sensitive policies, for instance, during COVID, and we do not find any evidence of any serious attempt, especially in LMICs, lower and middle-income countries, to address the issues of gender. Fundamental issues of discrimination and gaps in sexual and reproductive health remain largely unaddressed. And in some cases, the situation worsened with the rollback of rights, including, of course, abortion rights. And we also found that the worst impacted are socioeconomically vulnerable women and sexual minorities who saw what little services they had to begin with completely being taken away during the pandemic, during the shutdown. So shutting down of services for the poor and of organizations that work for the poor. And this is a very important point, that the community-based organizations, the NGOs that were actually doing something for the vulnerable population, their services were shut down as well. And that kind of compounded the adverse impacts. I will be touching upon all of this subsequently, but I want to touch on the second and the last point in my opening remarks, which is the impact of the lockdown and shutting down of economic activities. The whole world saw how millions of informal sector workers literally trudged home with their families, including women, children, and the elderly. We know that about 90% of the Indian workforce is in the unorganized sector, working in cities and towns far from their mostly rural homes. And the sudden and immediate lockdown in March 2020 meant that most of them were immediately put out of work. They were struggling for survival, economic survival as a result of job losses, hunger, starvation, persecution by state officials because of social distancing. All this just compounded their plight. Transport shutdown as well. So we have this horrific images of migrant workers and families and children and the elderly walking thousands of miles without food, water, and shelter. Now, these are both of these areas, the health as well as the livelihood issues, are really stem from policy gaps, and we will again come back to this. Apart from the visible migrant workers that we all saw visuals of, there are many others like domestic workers, self-employed workers, vendors, who were seriously impacted. So I want to just end by saying that the complete lack of social protection measures, including health coverage, combined with the non-resilient health sector and lax policies that govern how industries operate, have further aggravated inequities on all fronts. And the sad part is that the impacts on both health and economic livelihood fronts would be medium to long term and would go beyond the current generation and impact future generations as well. I'll stop here.
Great. Thank you very much, Indrani. And we'll come back to a number of the themes that you touched on there. I think they were really very important observations. But let me move on to now Dr. Tonatiuh Barrientos Gutierrez. And Tona is a medicine doctor with the Autonomous Metropolitan University in Mexico and a doctor in epidemiology at the University of Texas at Houston. He completed his postdoctoral training in social epidemiology at the University of Michigan, and he's currently the director of the Center of Population Health at the National Institute of Public Health and a member of the National Academy of Medicine in Mexico and a member of the National System of Researchers in Mexico. So Tona works in several areas of public health in Mexico, including COVID-19 and hepatitis, tobacco control, obesity, diabetes and cardiovascular disease, child development, and teen pregnancy. And currently, Tonatiuh is invested in the identification of structural interventions to reduce addiction, chronic diseases, and reproductive health inequalities. So, Tonatiuh, over to you.
Thank you very much, Nim, and good morning, everyone. Well, Mexico was heavily affected by the pandemic. We experienced high mortality and overall suffering. It's interesting, right? Because we are supposed to be an upper middle income country, and yet I think that this label actually hides the huge gaps in living conditions that we experience. I think in reality, Mexico is several Mexicos, and we have very wide differences by ethnicity, income, education, or access to welfare services. Our health system is historically underfunded, and it is also fragmented, so that formal workers receive a different quality of service than workers of the state or people who do not have a formal employment. And of course, a large proportion of our population is indigenous, and they are still living in very marginalized conditions with little access to healthcare services that are not culturally appropriate. We have also transitioned very quickly from a rural to a heavily urbanized country. And that happened very fast with little planning, and that has led to several inequalities. So during the pandemic, aspects like transportation, housing, and employment were key drivers of the differential impact of the disease. More than 60% of the Mexican population works on the informal sector, and they don't have any possibility for sick leave. So it is very hard to imagine how to, for instance, create an effective confinement when your basic sustenance depends on your everyday work. Also, a large proportion of the population lives in overcrowded houses that often host more than one family. And it is also very hard to imagine having, effective isolation under those conditions. But I think that beyond living conditions, one of the key factors that was very important for Mexico is the underlying health status of the population. We have a very high prevalence of obesity and cardiometabolic diseases that are a result of changes in our traditional diet towards more modernized diets. And of course, those things matter. We know that more than 27% of hospitalizations and 36% of deaths were attributable to chronic diseases. And these proportions were even higher among younger adults. So I think in general, we had, the perfect conditions for a perfect storm that differentially affected the poor and the marginalized. And I think at this point, we need to really start thinking and working on how can we do better. And I have some ideas here. I think the first one is that we need to invest with inequality lenses. And of course, let's think, for instance, about epidemiologic surveillance and which epidemiologic surveillance mechanism is not riddled by inequality. So if you use, for instance, syndromic surveillance and testing, you require healthcare access, but you also need transportation and time availability. We're hoping, that new population surveillance systems such as wastewater analysis will help us reduce that. But in reality, you need to have access to sewage to actually be able to be captured by this type of systems. So I think that we need to target our investment and we need to improve what we have, but we also need to recognize that these systems systematically exclude those that are always excluded. We also need to increase in local capacity, and we saw that very clearly with vaccines. Right, so Mexico does not produce vaccines, and we were dependent on the availability of vaccines from other countries. And of course, we were dismayed when we saw that there was no international coordination despite the COVAX initiative by WHO. So I think that low and middle income countries need to improve their capacity for vaccine production, distribution, and overall pandemic preparedness. But that is going to need very strong leadership. And I think that the only way in which we're going to achieve that is if WHO is strong enough to help us move towards that. And then we also need to invest in contextually relevant cooperation, because although we have learned a lot from high-income countries, often the solutions that they have are not necessarily the best for us. I'm really amazed about all of the fabulous technological solutions that are being proposed, but I worry that if we try to emulate that, we will end up spending our budgets while we could do something much more effective if we strengthen up primary health. So I do envision, a network of cooperation across low and middle income countries where we can share some solutions that are contextually relevant. And then finally, I think that we would hope for the best, but we need to prepare for the worst amongst the worst stuff. Because despite our best efforts, the next emerging respiratory virus could reach our population and disseminate quickly. And if that happens, then the strongest line of defense that we will have will be our underlying health status and the strength of our health system. So we really need to work hard to offer health and not only health care to our populations, and we need to do so in a fair and just manner. Thank you, Nim.
Thank you so much, Tonatiuh. That's a very powerful observation that our only line of defense is our underlying health status, and clearly we need to move beyond that. But again, some important themes that we'll come back to in the overall discussion. But before that, I'd like to introduce our final panelist, who is Dr. Mark Blecher, who is Chief Director of Health and Social Development at the National Treasury, South Africa. And a few words about Mark. His academic qualifications include a 4-year specialist degree in community and public health at the University of Cape Town and a PhD in the area of health economics. So he has over 50 publications in the field of public health and health economics, with a range of books and journals, including the South African Medical Journal, Essay Health Review, Vaccine, OECD book, and others. And Mark supervises a team of 10 in the National Treasury and has previously worked on policy and planning and health economics in the public sector. His work encompasses many areas, including national health insurance research and development, putting in place health conditional grants like the HIV/AIDS grant, heading the Health and Social Protection Fund committees, which make recommendations on sectoral budget allocations. And Mark's section of the Treasury also works on social grant modeling and budgeting, ECD, and other aspects of health and social development. He has also worked on aspects of social security development. So Mark was co-chair of the UNAIDS Economic Reference Group and works regularly with various global organizations such as WHO, Gavi, the Global Fund, GFF, and others. And he's currently co-authoring several international cross-country studies on UHC. Mark, over to you.
Yeah, thank you. Thank you very much, Nimalan. Greeting to all colleagues. I'm just going to talk fairly briefly on perhaps 3 problem areas we had pertaining to equity and maybe one more positive area, and then perhaps later on you may want to come back to, well, what could we do better next time? But I'll start a bit on the problem areas. So the first one really was just low-income and middle-income country access to vaccines, particularly in the early months, because I mean, it was really, really difficult for South Africa to get vaccines at all in 2020, those first 9 months. And I mean, about 70 to 80,000 people died in our country, while many richer countries at the time seemed to be getting vaccines. So, but what was, was so kind of particularly kind of aggravated this was that, COVAX really seemed like the best hope at an international effort to try and get vaccines to poor countries. But even COVAX was really, really struggling to get vaccines in that early part. So richer countries were getting the vaccines, but the best global attempt to get vaccines for poor countries was really struggling to get vaccines. So a country like ours then was basically forced to double order. We had to, put in orders to COVAX. We couldn't get them. We then had to put in private orders, and the contracts that we were being faced with were like highly secretive, extremely kind of unfair, and we couldn't discuss them with anybody internationally because of the nature of these contracts. So it was a very, very difficult situation. So really this is the first problem in a massive pandemic, just not being able to get access to countries in a very inequitable way. The second problem that I wanted to highlight is the effects on low and middle income countries of prolonged, very severe, what we call level 5 lockdowns, and the effects on income, poverty, and hunger. In South Africa, we had a very rapid introduction and long duration of almost 3 to 4 months, and then of the highest levels of lockdown of the economy, and then lower stages of lockdown for almost 2 years after that. And I think we perhaps followed some international examples in this and did not properly consider the equity effects of this on income, jobs, and hunger, particularly on the poorest. And I think there was quite a limited understanding globally about the ability of persons living in crowded shacks and townships to be able to comply with these kinds of lockdown measures. And the effects on our country were really quite devastating. I mean, we lost 2.8 million jobs within a month or two, and 2 to 3 years later, we still have 2 million more what we call NEETs, not economically employed or in training. We had very long queues for food. Huge worsening of youth unemployment. We had to put in place over 100 billion worth of income support in new social grants and UIF, but it just didn't meet the gap. We were in the worst economic crisis in a century with massive drop in tax revenue, and one of the biggest problems this led to was a massive increase in debt and interest payments, almost a debt crisis, which we have not been able to properly get out of. So now our national interest payments are 19% of revenue, over 300 billion a year, and they're squeezing out our health and social expenditure 3 years later. And whereas in 2020, yes, we put a lot of money in or reprioritized money to the epidemic, we've had to then cut budgets subsequently because of this recessionary and climate linked to debt servicing. And so going into the 23 budget, which is almost 3 years later, we were going into the budget with a 16 billion cut to our health sector, which we're trying to mitigate about half of that and to put back about another 8 billion, but we still have about an 8 billion cut to our health sector 3 years after the pandemic because of the economic crisis, which was linked to COVID, but also the prolonged economic lockdowns linked to COVID. So I think looking back, there was probably not proper consideration on options, on the optimization of effects on health and the economy, or the lack of models to properly consider these together. It was only kind of 3 or 4 months into the epidemic, we came across European CDC recommendations that maybe where something like business closures could be local and dependent on level of infection and other factors, but masking, for example, could be universal. We had gone into a kind of almost a universal closure of businesses, except for the most important. Then another problem that we had with respect to equity was very extensive closure of schools, which had very harmful effects on education of the poorest. And a lot of the poorest children did not have access to online learning options, e-learning and home computers and so on. So there's very marked equity implications in education. Lastly, one positive effect we had was that there was a far greater, the South African health system is typically very inequitable. But in the response to COVID, we had a much more joint public and private sector planning. People could get access later to vaccines in the public or private sector, whether you were being financed public or privately. So there was more equity in the options that were available. That was one good point. But back to you, Chairperson.
Great. Thank you so much, Mark, and thank you to all the panelists for some really fascinating insights. And also, of course, insights from such different geographies. So we're fortunate to have insights from India, South Africa, and Mexico. So I'd like now to go into a broader panel discussion now with all 3 panelists. But what I'd like to do is to structure the discussion over the next half an hour or so around 2 themes. So to begin with, I'd like to talk about basically the inequities that were observed already, that were revealed by the pandemic. We've touched a little bit on some of these already, so that we can basically see, what it was that we learned from COVID. And then I'd like us to move on then to what we should do better in future pandemic response in perhaps the second half of this discussion. So again, for those of you in the audience who would like to pose questions, please feel free to post these in the Q&A. So Tona, I'd like to start with you. You mentioned a fascinating point. I mean, we tend to think about outcomes and so on, but you mentioned the point about surveillance, and that I think you mentioned surveillance itself can be riddled with inequity. Could you say a little bit more about the different ways in which inequity affected surveillance in your setting?
Yes, thank you. Well, I think it is, a matter of most of the epidemiologic surveillance being dependent on health services. I think that we have a very passive standpoint regarding surveillance, where we are expecting people to, get themselves to health services. And of course, that requires, for people to have access, to start off. But then also you need to have the money and the time to get there and to stand in a queue and wait to get tested. So, for many people, the waiting times could be very long, particularly at the beginning of the pandemic, where we did not have, such a wide access to testing. So I think that we really need to start thinking very carefully about other ways in which surveillance could take place, so that we can offer a much more equitable access to disease detection. It is amazing, because even if you base your surveillance systems in things like hospital beds, again, you need to have access to hospitals, and even things like mortality registries very often undercount the number, for instance, of deaths in very marginalized communities. So I think that we really need to look upon this from an inequality lens and think very carefully about how to improve that. And I think a key step is going to be to become much more active in terms of the possibilities of reaching out populations. And that's why I was talking about primary healthcare and strengthening primary healthcare as a very strong community access system, and I think that we have been lacking that here in Mexico and very likely in the rest of the countries, because we have invested a lot in very specialized medicine, for instance, without necessarily paying a lot of attention to primary healthcare.
Great, many thanks, Tona. And I'd like to invite Indrani and Mark as well to comment on whether you observed any inequities in surveillance as well in your respective settings in India and South Africa. Perhaps Indrani first.
Then we know that there has been debates around our numbers. Indian numbers on COVID mortality have differed widely from what other experts have estimated. And we don't really, like Dr. Gutierrez has already mentioned, we don't really have a good surveillance system either. And for the same reasons as in Mexico, the medical attention at death is very low, and hospitals don't report on time. So we haven't really counted our deaths, well during the COVID pandemic. And I think the reason would be the same. We don't invest enough on the health sector. India spends about 1.1% of its GDP on the health sector. It's remained the same even post-pandemic. And that has been very, very curious that we have not been able to increase our health spending. And so all of this has resulted in poor surveillance. And even to date, I don't think that we really know what really happened during the pandemic and how many deaths there were. But if we do start counting, and if we believe some of the numbers that people like you or the modelers have come up with, then the impact must have been, huge and devastating, and must have fallen, unfairly on the poor and the marginalized. But we don't have hard evidence on that, and the government also doesn't really want to discuss this, as you know. So yeah, those are my quick comments. And I think the neglect of the health sector is something that has really bothered many of us who work on the health sector for years. And we would like to see in the coming years, before another pandemic hits us or another COVID variant hits us, that we are able to invest much more, maybe 3 to 4% of our GDP on the health sector. But we are very far from that goal. Thank you.
Great. Thanks, Indrani. Mark?
So in South Africa also there was quite substantial underreporting of deaths in the main form of national mortality reporting. Fortunately, we had a very good group of scientists from our Medical Research Council, some of our universities, who published the excess deaths data weekly, which was really excellent. And it really helped to give a better balance to the situation, although some didn't want to accept the severity of the data that was being reported. But it was really, really useful, and it created useful national debates about the severity of the epidemic. So that work from the scientists was really good. We did have quite a lot of problems in availability of diagnostic testing throughout the epidemic. Although we have only 20% of the population are rich enough for private insurance, there were always more diagnostic tests, COVID tests being done in the private sector, the 20% insured, than the 80% in the public sector. So there was, much less access to testing. It was, much more difficult. And even today, 3 years later in South Africa, the kind of tests that in Europe people buy in the local pharmacy for home testing are not yet available in South Africa. You don't get them here yet. So quite a lot of problems of access to testing, but even in surveillance from our side. Thank you.
Great. Thank you very much. And thank you to all the audience that are sending in questions. I'd just like to touch on one of these, and we'll come back to these questions later, because some of these relate to what we should do in the future. But Tona, maybe this relates to a comment that you made, which is the need for contextually relevant cooperation and contextually relevant interventions, which is that, so the question reads, surveillance systems do not need to be very complex, and they're long-standing and interesting systems like in malaria and polio, which are not very sophisticated, not very costly even, but are effective. And how do we build those up in NMIC and LIC settings?
Yes, thank you. So one of the things that I found out really, really amazing is that when we were looking, at the different ways in which low and middle income countries were trying to fare the pandemic, there were great ideas there. And they were ideas that we could have brought up to Mexico much quicker if we had like a better communication and a better cooperation. And that's why, I'm advocating now to create this network of cooperation, because precisely things like, much more appropriate ways of surveillance, but also, like different opportunities and mechanisms to reduce the impact of the pandemic are widely available in other countries. But it is a matter, of being able to communicate. But the problem with that is that I don't feel that we have, like a very strong setting, infrastructure to actually share those ideas and move this quickly enough so that we can bring those ideas into our countries. And what I do see is that given that we have a stronger infrastructure for communication with high-income countries, then often the highly technological and very expensive options are the ones that we are discussing, when we should probably be discussing cheaper, but also perhaps more effective interventions. For instance, Mark was talking about the complexities of trying to implement confinements, right, with low-income populations, informal workers. And I think, many of the things that we have learned in different countries should be shared so that we can actually implement those in an effective manner.
Great. Thank you. And my second question, and this is to Indrani, but again, I'd like to invite the other panelists also to weigh in after this. But Indrani, at the end of your comments, you made a very interesting observation, which is that the negative effects of the pandemic in terms of inequity were not necessarily felt during the pandemic as well, but could have long-term implications too. And I just wanted to ask if you could elaborate some more on that, but particularly in the question of, we know there are inequities. We've heard about how many of these existed before the pandemic. In what ways have these been further entrenched in the longer term as a result of the pandemic?
Well, the first thing is that if you just count the poor, during the pandemic, I'm sure the head count would have gone up, and there would be multiple deprivation parameters among these people. A couple of things, the health outcomes that we are not counting. We are not really doing very good analysis on of what happened to the non-COVID health issues. There's bound to be, we have been seeing increasing NCDIs and also, of course, communicable diseases. So we really don't know where the people really went when they were sick. Or so we have these images of, this goes back to the surveillance of dead bodies floating in rivers. It's a horrific image that has stuck, in our minds about India. So we know that people were dying, whether they were dying from COVID or they were dying from other diseases. We really are very unclear about that. So there are families that have been destroyed. because of deaths, as well as other issues like hunger. Malnutrition would have gone up. Hunger index, we are not doing very well on that either. We have slipped down, as we know. So, these are bound to have long-term impacts. And then there would be many single, headed families. The one person is not there. Children's education, they have lost out a couple of years. The digital divide, all of that, everything that happened, and we all know all about those things, would obviously have multi-generational impacts. It cannot be contained in one generation. We are not doing anything much about what has happened also. I mean, it's not as though we have just swung into action and everything is hunky-dory. It's not. So we continue to see impoverishment, we continue to see unemployment. And India, while before the pandemic, a few years before the pandemic, we were doing fine in economic growth, GDP growth, but just prior to the pandemic, we actually were doing very poorly. Growth rates had fallen. So on top of high unemployment rates, we saw this happen, the pandemic impact come in and accentuate those things. So I think unemployment, poverty, hunger, malnutrition, families shrinking, the economic burden would be huge and would be felt. And it's like any other epidemic. When we were working on HIV/AIDS, we saw the same thing happening in multiple generations. So same thing is bound to happen here as well. Unless we swing into action and bring in all the social protection, the cash transfers and helping the children with their education, all of that very quickly and very fast. And I don't see that happening.
Great, thank you. And just to invite the other panelists also to weigh in, perhaps I'll start with Mark. I think, Mark, you touched on some of the severe macroeconomic effects that had happened as a result of the pandemic. And I think, correct me if I'm wrong, that South Africa's GDP contracted by 7% as a result of the pandemic. And so, again, are there ways in which the pandemic has entrenched existing inequities in the long term?
Yes, so let me speak to four, some of which I did mention earlier. So firstly, the effects in South Africa, but also in at least 50 to 60 other countries on health budgets. So the World Bank brought out a publication, it's called From Double Shock to Double Recovery. They brought out two versions of it. And they show that at least about 57 countries had such a severe economic impact from the pandemic and the response to that, the pandemic, that it severely threatened their health budgets going forward. And South Africa is one of those countries, and I tried to describe that when I talked previously. It's a very acute problem for our 23 budget going forward for health. Secondly, the loss of jobs, particularly youth jobs, has been tremendously harmful for us. We have a youth unemployment rate in South Africa almost unprecedented anywhere in the world, of the order of about 50 to 60%, and it causes great social destabilization. It led to massive riots in KZN. So huge problem of unemployment and youth unemployment and linked social instability. Thirdly, a lot of progress was made on building digital social security systems and new forms of social grants. But with the Ukraine war and the global inflationary climate, we're now in a massive global pressure on cost of living increases, which is aggravating the loss of jobs which have not recovered properly after COVID. And then lastly, as I mentioned, we severely aggravated our debt situation because of COVID. Revenue was massively declined, spending was massively increased. We had to take large loans, and it's going to take us quite a number of years to get out of, and that is squeezing out health and social expenditure. So four fairly serious implications which we have to try and now grapple with going forward, and they partly all linked to the inability to properly match the economic and health aspects of the response.
Great, thank you very much, Mark. And Tonatiuh, any comments from the perspective in Mexico?
Yes, perhaps I think my colleagues have already touched, on many of the things that we're also experiencing. So, but perhaps two or three things. First, we saw, an increase in food insecurity in Mexico during the pandemic, which is already something that it's quite frequent in the country. And I think it is a reflection, of the overall complications of the economic situation in the country. And of course, that worries us a lot because it doesn't necessarily undertake us to undernutrition, but to poor nutrition in general, like cheaper food that is not necessarily going to be healthy. Then, the health system in our country was very, very demanded, and in many ways we had to reconstruct the health system very quickly to be able to respond to the number of patients that we were seeing in hospitals. And of course, that represented, a big problem because we ended up having to put people who needed healthcare, for chronic conditions such as cancer or diabetes or cardiovascular disease. We didn't have, the ability to actually cover all of those needs. And that is something that we have seen reflected on excess mortality. And that goes back, to my point of the need to improve the population health. If we really want to fare better in the next pandemic, because of course now we recognize and we are working to try to improve healthcare services to cover all of those needs that we couldn't cover during the pandemic. And for instance, a couple of things that are very, very important is vaccination, and vaccination for other things than COVID, right? So it is quite important that we catch up, and during these years we have actually reduce our ability to provide coverage for children, for instance. And then there is another thing that we're worried about, and it is reproductive health. We have seen an increase in maternal mortality, something that we did not see over the last years. And of course, a part of that is related to COVID itself and the risk that COVID implies for women who are pregnant and for little children. But there's also, some backup on the provision of services, reproductive health services overall. So I think that it's going to be challenging over the next years to get the health system to right pace.
Yes, some very important observations. But thank you very much, panel. And in the remaining time, I'd like to make sure we pivot to thinking a bit more about the future and what it is that we should be doing better for a future pandemic response. And I'd like to start, Mark, with an observation that you made, which is that the lockdowns and the restrictions were pretty blunt tools, not just in terms of controlling infection, but also in terms of the economic damage that they caused. And you've written about the need for more targeted interventions and commented on that as well. So you touched on that a bit. I wonder if you could elaborate a bit more on some possible approaches in future for more targeted interventions that could still have the necessary health impact, but without the severe economic cost that we've seen.
Okay, thanks, Nim. So, I mean, I think it has been a lesson for many of us of the need, firstly, to bring, in some way, find ways to bring epidemiological and economic modelling more closely together, because they were very separate in our country, and in a sense, the different parties didn't really want to collaborate closely together at the time because each felt the kind of urgency and primacy of their own field, and it was quite difficult to get them to collaborate. And so looking back, I mean, I think, the methodologies for that were not really strong, but also the channels of communication and collaboration were not strong enough. So, I think that's the lesson. And then I think, looking back also, perhaps we should have had more clearer objectives on both sides and more option appraisal. I mean, we had a very good epidemiological group set of modeling consortium, but they were focused more on kind of projecting where the epidemic was going, rather than trying to, in a sense, appraise options of different interventions. Now, that may be a little unfair because, many of them will say, well, they didn't know the effectiveness of any of the interventions, so it was really difficult to model at that point. But, I think it would have been helpful to think more about different types of options, perhaps more shorter focused interventions, I mean, something like, just something really simple, really only occurred to us kind of 4 months later. Did you have to close all these businesses as opposed, for example, to have low flow of individuals going through the businesses with masks, for example? It took us 4 months to learn that lesson. Couldn't one have thought of options like that and maybe modeled them earlier, given the massive effect that it ended up having? So, yeah, I just think more openness to those kinds of options would have been helpful. Thanks, Tim.
Great. Thank you very much, Mark. And in Indrani, I wanted to pick up on a point that you mentioned earlier, which is on, and again, this is something that you've written on previously, on internal labor migration and how some of the poorest were worst affected by the lockdown restrictions. And again, in terms of lessons learned for future pandemics, in an emergency response like that, what would be a better response, would you like, if you like, to better protect people who are worst affected in that way?
Actually, I want to step back a bit and say something which is not politically very correct. Is that's that, why did we have to actually deal with the migration issue? Why couldn't we not have anticipated that this is going to happen, as though we didn't know? I mean, the reason being that this group of people and all the other so-called vulnerable population, they have remained invisible for a very long time. It's not only the pandemic. It's just been a kind of an issue that we have dealt with for a long time. And because they were so invisible, and we know that our formal sector also depends on the informal sector workers. It's a very strange situation that only 10% of the workers are in the organized sector. So this is common knowledge that there's this informality of workers that run the small and micro enterprises. But somehow we never thought of them. The fact that we didn't think of them, and there are multiple, as I said, these people are not only migrants, they're also often scheduled caste and tribes. They're just living on the edge of poverty, religious minorities. There are all kinds of people in that group, and then there are more, of course, outside of the migrant group. The fact that they were invisible to the policymakers and we did not anticipate it tells you a lot about policymaking in our countries. And so I would say that the migrant problem, of course, there are many aspects to the migrant problem. One is on the labor market itself, how we have dealt with the labor market, how we have enforced rules and regulations, how enterprises get away by flouting rules and doing exactly what they want by giving them low wages and making them informal so that they don't have to give them any social security. All of that is also there. So there is a bit of political economy and a bit of, management, etc. that come in. But at the end of it all, I think it's about time that we recognized who these people are. And I want to say one quick thing. I know we are running out of time, which is that whenever you, the NGOs, the community-based organizations, and other people who work directly on the front lines, they were the people who were able to actually deal with them. And local governance, Kerala has a model of local governance that has worked pretty much, it's not there in all over the country. So there are things we could have done, we could have anticipated that we didn't do. And it's really a pity. So I think this time around, if we can pull up our socks, look at the labor market situation again and see what we can do better. Look at social protection and target people who are actually in a deprived situation and give cash transfers to them. I mean, how difficult was it to give cash transfers very quickly? And we are so proud of our digital thing, our technology. We could have done something. We did subsequently. It's not that we did nothing. I mean, I don't want to say that at all. But, timing is so important. When you have already lost people or made hunger indices go up, you can't do that. You have to do it then. So I think that now we need to focus on the health sector, increase health investments, make health sector more resilient. Why is it that primary care is so abysmal in the country? I mean, that's something that came from our Mexican colleague as well. look at the labor market situation very closely, look at local governance, and because these are the local governments would be best suited to do both surveillance as well as dealing with socioeconomic livelihood issues. Thank you.
Thank you very much, Indrani. Some very powerfully made and extremely important points. And I wanted to come to you, Tona, but given that we're running a bit short on time, I just wanted to maybe start wrapping up with a few reflections from all of you. And maybe, Tona, I can start with you on this, which is just hearing the panel speaking, it seems to me that one of the really important things that come out of this is, we're talking about this in a pandemic lens. How could we improve pandemic preparedness in future? But really, it seems as though a lot of the things that we're talking about is actually improving equity and basic healthcare service provision. It doesn't need to be seen through a pandemic lens. And so the hypothesis that comes to mind is that if we basically if we improved our governance, improved our policy making in such a way that we could capture better equity in public health, then a lot of the problems that we're thinking about in equity and pandemic response would follow from that. Do you agree? Tona, first, please.
Thank you, Nim. Yes, I think I agree overall. I think that sometimes it could be easy to judge, right? Like the decisions and the way in which the pandemic was managed, looking at the rearview mirror, and we can be unfair, when doing that, because as Mark was pointing, there was a lot of unknowns. But I think that one of the things that we do have to do is that we have to learn. We have to learn, and we have to act. And I share, Indrani's concern about knowing if we are really moving forward with a sufficient speed towards getting better prepared for the next pandemic. And I do feel that we need to start by recognizing that preparedness and response plans need to be better grounded. We need to understand better our specific situations. We need to recognize the shortcomings of our systems. We need to better understand our populations, and particularly, we need to start thinking about how is people going to fare the pandemic, particularly those who are very poor and who are very marginalized. I think that sometimes we take the best situation to try to propose a plan when we should actually look at the worst stuff in our society. And one thing that I do see, like very urgent is we need to define a framework of research questions that we need to solve urgently, and that have to do with our specific contexts. Mark has said many times now that we really did not have, like a very strong evidence base to make decisions in the first months of the pandemic. And I do agree with that. It was really, really hard to make decisions, good decisions, without having sufficient evidence. And now the question is, are we really changing our research frameworks in our countries and actually answer some of those questions with enough strength? And just think about face masks, right? So it took us a lot of months to get a good answer, and even years, to start getting the results of randomized trials. So the question is why? Why is it that we didn't invest enough and we didn't ask, the right questions? But now I think the pandemic taught us very well that for instance, non-pharmacological interventions are going to be key in the first months of the next pandemic. So we need to start understanding better how to make those work for all people in the population, and not only people who is going to have quick access to the. What I think is we need to look very carefully at that. We need to learn from each other. We need to cooperate more, and we need to have like a better communication across countries that share the similar problems, such as South Africa, India, and Mexico. Thank you.
Great, thank you very much. And in the time available, I'd like to maybe ask Indrani just for a closing comment on this point.
Well, we saw in India when the pandemic struck us, how we didn't have PPEs and gloves and all of that, and we had to start importing. But in real time, we cranked up production, so we could have done it earlier. The fact that we did not prepare the health sector for pandemics and epidemics is a big learning, thing for us. And I hope that this time around we will do that. That's one. The second is that medical products, technology, these are low-hanging fruits, and those things have happened, and the international world also has helped. Vaccines, for instance. But what has been a bit less focused on are economic livelihood issues, because those are difficult to deal with, and those are very domestic in nature. So I think there is now a real need to focus research as well as policy on how we now refocus our attention on the most deprived, so that next time around they are not the people who are hit the hardest. So I just stop here. Thank you.
Great. Thank you very much, Indrani. And I really wish we had more time for discussion, but the hour has come, unfortunately. But I think that last statement was a really great summary of the overall discussion, the need to focus our efforts to protect the most vulnerable in future emergencies. But Neil has now joined us, and before that, I just wanted to thank all the panelists very much for your valuable time. It's been a really wonderful discussion. And Neil, can I hand over to you?
Thanks, Nim, and I'd reiterate your thanks for the panelists here, but also for the previous sessions and all the chairs. I mean, it's been a really fascinating symposium overall, and it's difficult to summarise in a few short remarks, but I think it's been nice the way we've pulled people together in each of the sessions from a range of backgrounds, all the way from the private sector, bank, or the World Bank, academia, and ministries of health and the clinical side, as well as behavioural scientists. There's some common themes which have come out. One about heterogeneity across different experiences of the pandemic, both over time between different countries and then between different population groups, and particularly marked in the last session by the inequity in healthcare responses. But turning to the first session, I mean, some of the challenges were highlighted of funding pandemic responses. I mean, I was involved in discussions with the World Bank well before this pandemic in terms of insurance-backed pandemic risk mitigation, but what the COVID pandemic has shown and highlighted by that symposium, but by that session within the symposium, is that the scale of something like the COVID pandemic is impossible for any one industry such as insurance to cope with, and will require public-private partnerships going forward. It also has that cost has accentuated the need for improvements in preparedness, and it was highlighted that just understanding the economic impact of the pandemic is very much a work in progress. It changed at different time as the pandemic progressed, as industries adapted, but also was very different between different countries, depending on both their economic development stage, but also the policies enacted. Session 2 is fascinating, looking at the interaction between behavioural sciences and population behaviour and what happened with the pandemic in terms of interventions, highlighted some of the gaps in understanding and research priorities, in terms of we don't have predictive models of how populations necessarily will respond, at least at the level of detail we'd like to be able to predict these things, but highlighted the fact that actually, as well as mandatory interventions, there were really major changes in population behaviour caused by the pandemic, by the perception both of risk and carryover from the measures adopted, and that we need to be better at understanding how to improve messaging and refine policies in light of the learnings we've got about how populations and individuals respond to those messages. And finally, the last session just highlighted something we of course know, that this pandemic has affected the world's poorest. by far the most, both in terms of what we see in terms of inequity and heterogeneity in terms of who has suffered within countries, but also the global south having endured certainly the economic brunt of this pandemic, if not necessarily the brunt in terms of healthcare. But we heard that really the pandemic in the three countries, India, South Africa, Mexico represented, which are some of the worst affected countries in the pandemic, that just as frankly in the UK, that the experience of the pandemic and the public health and the health impact of the pandemic really built upon a pre-existing high level of health inequity, both in terms of access to care, but also in terms of, and perhaps interestingly, in terms of the burden of comorbidities in the population, which of course predicted severity. Anyway, I'll stop there and just thank the speakers and the chairs once again, and thank you, the audience, for attending. Next year, I think we will actually do this in person finally. Has pluses and minuses, but it is good to see people. But thanks again, and we will see you soon. Thanks.